comes in, we are. And the doctor comes in, the patient's on the stretcher. And are you nervous? You nervous, Tom? I'm excited. Me too. That's exactly right. So Dom was with us for 7 years, and he was instrumental in developing and nurturing a lot of the things that we do with our pediatric spine program now, such as our, rapid pathway, AIS, halo, rapid traction, and I think many of us remember Dom, and we remember his commitment to education, and we remember that in our conferences, he used to kind of tweak our curiosity and kind of ask us why we did things orthopedically and make us kind of really think about this. And there's many reasons why it's not just because we have the same songs. And we never had to change the table height. Two stools. But Dom is, right, he's inquisitive, which I think is what makes a wonderful. He's a meticulous surgeon. That's with him know that, and he is the consummate educator. I know from my experience, Dom, he's a better surgeon. We've been trying to get Dominick to come back. Okay, every time we see him, ask him. Once he's back today.
Thank you to the entire team. I get to talk about a really fun topic today, which is building teams, but not only teams, but great teams. And was definitely fortunate to be a part of this wonderful team here for 7 years. These are my disclosures, none of which are really relevant to our talk today. But I think the pictures tell the story here in terms of what this group has meant to me. I was very lucky to come out of fellowship to be a part of this wonderful team with Andy, Tom, Steve, Heather, Dave, Phil, Skip, Deidre. I think it really had a family feel. I feel like sometimes I was joking this morning that this is like the college kid who went away for 2 hours north and comes back, and we all still keep in touch, and the friendships that were built are lifelong. And I think it's an appropriate way to start this talk, is really at the core of the talk is relationship building. I really want to thank also Charlie and the department for welcoming me back, and to Michelle as well for coordinating this visit. So to paraphrase from the book that I'll be referencing frequently throughout this talk, this is clearly a place where the right people are on the bus. And a lot of credit should really go to Skip and Andy for being prescient in establishing a dedicated pediatric spine team before it was really popular to talk about it on the podium or to publish about it. And so even when I got here in 2012, there was already a set group of OR personnel, including circulating nurses, scrub technicians, radiology techs that were in there for every pediatric spine case. And that was no coincidence, it was very intentional. There was a co-surgeon for every pediatric spine case. We had an amazing nurse practitioner, and still have one here in Colleen, and clinic nurse in Sandra. Great floor nurses and physician colleagues. And these were a lot of the lessons that I learned and gleaned from being here that I took with me to New Haven. When Dan, and thank you, Dan, for being the one to initiate this whole process of having me come back, when he and I were speaking a little bit about what I wanted to convey to our group of residents here, He really just said, I want to hear about the process of transitioning your practice from Robert Wood Johnson to Yale. What were some of the lessons learned and principles followed? And I highlighted some of the residents here that he told me may be interested in a field like spine or joints, where there's some commonality in terms of needing dedicated teams, working with complex implants. But I hope that some of the principles will really resonate with the entirety of the residency program, irrespective of what subspecialty you'll be going into in your careers. So this is the book that I referenced in the title, Good to Great by Jim Collins. It was written in the early 2000s. It's a business book that talks about differentiating factors that distinguish great companies from good companies. And so these are a lot of the principles, and maybe I guess if you want to use a sports analogy, the playbook that I kind of referred to when I thought about some of the steps that I would use in transitioning my practice from Robert Wood Johnson to Yale. And so the principles include level 5 leadership, and we'll talk a little bit about what that means in a few slides. The second principle is having the right people in the right place are the foundation of greatness. So getting the right people on the bus. Success comes from tiny incremental pushes in the right direction. The book refers to this concept as turning the flywheel. New technology should be seen as an accelerator towards a goal, but not as a goal in and of itself. And then finally, and probably most importantly, success requires facing the nasty facts while never losing faith. So the objectives for my talk for the next 35 minutes will be to review the previous literature on the value of dedicated teams in orthopedic surgery, to discuss the critical steps and key ingredients in building a dedicated team that is equipped to deliver outcomes of the highest quality and value, and then to examine some of the improvements that we saw in the first 3 years that I've been at Yale, resulting from the application of these steps, and then to talk a little bit about how to sustain these processes and results. And so what is level 5 leadership? I think it's really having that unique combination, not only of professional will, but probably more importantly, personal humility. Professional will is doing what must be done, no matter how difficult it is, generating excellence in a team's outcomes, and taking actions to ensure that the team and mission will endure beyond your tenure of leadership. Personal humility means never being boastful or overly welcoming of public praise, emphasizing a standard of excellence over your ability to inspire through charisma, using your personal ambition to make the company or team greater rather than making yourself successful, and looking to yourself importantly when things go wrong instead of blaming others or external factors or bad luck. I think that this key factor is what separates a level 4 egotistical leader from a level 5 leader. I think an important concept to discuss is that you can be a level 5 leader starting out into a new practice, even if your academic or job title doesn't include chief or director of anything. Creating your own little pocket of greatness, I think, is a good goal to have when you're starting a new practice. And identifying your cause or core value proposition, what is it that you can be great or exceptional at? And this is what the book calls the hedgehog concept, which comes from an ancient Greek parable that says that the fox knows many things, but the hedgehog knows one big thing. And so the intersection of these 3 circles and the picture to the right here, what are you deeply passionate about? What drives your economic engine? And what can you be the best in the world at? I think if you can identify where those 3 circles intersect, then you have your hedgehog concept. And for me, I think the goal has always been, given the skills that I developed in fellowship and my interests, was to provide the best possible high quality care for kids with spinal deformities and pediatric orthopedic issues. And so the first test that I encountered of this professional will and level 5 leadership when arriving at Yale was really just dealing with hospital administration and answering questions about why do you need to have a dedicated spine team? And really, this was one of my first big goals because I wanted to replicate what Skip and Andy had done here. But obviously, hospital administrators dislike dedicated teams. They like jacks of all trades. On teams, employees can gain some specialized skills and may lose some general skills. They gain loyalty to your team and maybe too much. Some teams, especially the spine team, may be more fun or finish earlier. And managers, as a result, can lose flexibility for cross coverage when they need it for illness or turnover. And so the response was recalling a phrase from a colleague named Jack Flynn at CHOP: pediatric spine is a lot like cardiac. So playing to what hospital administrators know. And then it came to explain why. For pediatric spine, anesthesia is special because you need neuromonitoring. And you need to be able to keep your mean arterial pressures at a certain level throughout the procedure. The instrumentation is complex. It's common. We do these every week. The cases benefit from efficiency. The stakes are high. There's no room for rookie errors, and better outcomes drive more volume. Again, speaking their language a little bit. And this helped me to kind of get to where I wanted to be in terms of being able to establish a dedicated team. The other advantage that I had that Skip and Andy didn't have when they were establishing their pediatric spine team here was that there is now a lot of literature that talks about the value of dedicated spine teams in reducing complications, reducing surgical time and cost, improving care for children with complex conditions, and I think ultimately makes your life easier and more enjoyable. And these principles, again, I think apply not only to pediatric spine, but also adult spine and joints and other subspecialty fields within orthopedics. So just to do a deeper dive into some of these articles briefly, this is probably the initial article by Raj Sethi, who's an adult spine surgeon, orthopedic trained at Seattle Spine. And they looked at a group of patients who were treated initially by a single surgeon, and then their group B was a dual surgeon team approach with a neurosurgeon and orthopedic surgeon who were also being treated after a preoperative multidisciplinary conference. They found that the latter group had fewer complications, fewer unplanned return to the operating room, fewer infections, and lower rates of neurological complications. In 2018, Jack Flynn built on this, looking at the pediatric spine realm, and showed that there was a cost reduction of $6,000 to $9,000 per case when doing cases with a dedicated pediatric spine team. The case time was reduced by almost 2 hours for uncomplicated cases and by 77 minutes for more complex cases. And then finally, Dave Skaggs again showed that having dedicated scrub technicians and dedicated spine nurses had the following effects: lower operative times, decreased blood loss, and importantly, decreased need for blood transfusions after spine surgery. So I think summary of principle 1, level 5 leadership, it really requires that unique combination of professional will and personal humility. You really want to be on the lower right quadrant of this graph with the low ego and the high resolve. Choosing a cause or a core value proposition that you can be great at, that hedgehog concept, I think is really key. And having a strong understanding of this core value proposition and a devotion to this mission makes it easier for you to handle potential obstacles when starting a new practice, like dealing with hospital administrators. So principle 2 is getting the right people on the bus. So after getting that approval to build a team, the challenge was really to find the right people for the team. Here's a picture of our scrub technicians and circulating nurses here at a happy hour in New Haven. My main prerequisite for being part of the Yale Spine team were really just a desire to contribute to and to be a part of something great. So I really wanted to try to figure out who was intrinsically motivated, and really didn't necessarily need to have people who had a lot of previous ortho experience. Because I think if you take the right people who have that intrinsic motivation, you can teach them skills and they'll learn pretty quickly. And I'll show an example of that in a few slides. The other prerequisites were I wanted them to come to our monthly meetings and also not to be afraid to speak up, irrespective of their role on the team, and to tell me things like, "Doc, we have too many sets open," or "This new navigation system has plenty of bells and whistles, but I'm not sure that it helps us at all. It doesn't make you any faster, and it introduces too much potential for field contamination." So these are the types of feedback that I've gotten over the years, and I think it's important to be able to set that tone with your team, that you want them to give feedback so that we're all accomplishing the common mission of providing great care for patients. So the team consists, very similar to here, of circulating nurses, scrub technicians, implant reps, nurse and research coordinators that help us do research to evaluate our processes, our anesthesiologists. We have a great team of pediatric anesthesiologists at Yale, our physical therapists who help our patients recover afterwards, our floor nurses who help take care of our halogravity traction patients in child life, nurse practitioners who double as surgical first assistants, and then for select cases, our neurosurgeons. So that's the entirety of the team that we've established at Yale. And I think the importance of the first assistants cannot be understated. Obviously, I had been used to having a co-surgeon at Robert Wood Johnson for all of my pediatric spine cases. And I think probably that evolved from sometimes having inconsistency here of having availability for residents, especially if you have a team of 8 pediatric orthopedists and only 2 residents on service. But even at a quote unquote major academic center like Yale, you can have difficulties with consistent resident availability. Especially for me, because one of my OR days is Friday, where the residents have mandatory academic time. And so I really wanted to have a consistent presence as a first assist to help minimize variability in my performance for these spine cases, as well as outcomes. And so Amy Noyes, pictured here, she's a nurse practitioner in RNFA. She initially was very excited about being a part of the spine team, but had zero spine experience. And I knew she was intrinsically motivated. She's former Navy, very disciplined, and said, whatever I need to learn, I'm going to learn. But just be patient with me. And she definitely had a steep learning curve at first, but now she's really an indispensable member of my team. So she assists all of my AIS and neuromuscular cases. She'll take a step back if she knows that the resident or the fellow will be there. But oftentimes it's fellows at an interview or the resident is at education or gets pulled to a different case. She's my first assist, and that really has been valuable. So I always tell the fellows that I work with, you can kind of find an Amy equivalent in your practice. I think it's really valuable to have. Our neurosurgery colleagues, Mike DeLuna here is pictured behind a 3D printed model that I'm holding of a complex case that we did together. They are an incredible asset to our team. We collaborate on congenital curvatures requiring 3-column osteotomies. The title of the article that's above Mike DeLuna's picture is by Chris Ames from UCSF. And it really showed that a combined neuro-ortho combo led to a 2.5-hour reduction in surgical time and 20% fewer complications in their series of patients requiring 3-column osteotomies. It really is a situation where we have complementary skill sets. I'm always impressed by the skill level of the neurosurgery residents as well. And I think one key element here is that in order to really maximize the benefit of working with a co-surgeon, it obviously does decrease your stress level, but I think that it's really important beforehand to communicate and to have a high level of planning before the actual experience. And so our first kind of forays into working together, we did cases that were maybe a little less complex, but allowed us to develop a rapport with one another and a communication style to be able to carry out these more technically complicated cases in an efficient way. So summary principle 2, having the right people on your team, getting the right people on the bus. The foundation of success for you is going to be having the right people on your team. First who, and then what. And it's important to choose intrinsically motivated, disciplined people because they can more easily adapt to a changing world. And then for you as a leader or as a manager, the problem of how to motivate and to manage really goes away because people on your team are self-motivated by an inner drive to produce the best results and to be a part of something great. So the third principle is that success comes from tiny incremental pushes in the right direction. And this is called in the Good to Great book, the flywheel effect. Success, although it may appear to happen overnight, really doesn't occur that way. And so once I knew that I had the right people on board, I needed a forum to show the team that what we were doing was worthwhile, that these incremental pushes in the right direction were worthwhile, and that it was working. And so that's where we brought in this monthly Pediatric Spine Quality Improvement Conference, very similar to what Andy runs on the Pediatric Spine side here. And it's an opportunity for us to review every pre-op and post-op pediatric deformity spine case. Here's an example of what our slides look like for the opening slides. It's usually a running tally of how we're doing in terms of length of stay after adolescent idiopathic scoliosis surgery, as well as a running tally of our surgical site infection rates. And then we jump into a case-by-case basis of cases that we did the prior month, as well as the upcoming cases for the next month, so that the entire team has a level of shared consciousness and a preoperative game plan for all the cases we're about to do. So the quote unquote breakthrough, and we looked at this and studied this after 2+ years of monthly meetings, the impact of having a spine team and monthly PD spine QI meetings at Yale, which we're going to be presenting at a spine meeting next month. This was a retrospective review of 180 patients, 2 cohorts, again, pre-QI meeting and post-QI meeting, very similar to Raj Sethi's 2014 paper. We showed that even though we were doing more osteotomies in the after group, our estimated blood loss was significantly lower by 500 cc's. Our intraoperative blood cell transfusion dropped to single digits, and our procedure time went from almost 7 hours to 4.3 hours per case. We also revamped our perioperative recovery pathway and found that we had patients walking longer distances, even though they were staying shorter, on average from 4.8 days to 3.2 days. So the summary and the take-home point from this flywheel effect being in action was that these pediatric monthly meetings are easy to implement, and now we're actually doing them virtually. They don't require a lot of time. They provide educational benefit for our learners, and they also foster team cohesiveness, probably the most important thing. In our cohort, two and a half years after the implementation of a monthly pediatric spine meeting, we saw improved patient care as measured by the parameters mentioned in the previous slide. Probably the most important part of these meetings is also it provides a visual reminder that our team's work is special and the results are great. And this is our first tailor gravity traction patient in Connecticut, who is a big basketball fan. He spent a month with us, and Colleen knows the effect that these kids have on the nursing team, and child life, physical therapy, the nursing staff, all really were integral in taking good care of Justin. And then one of the local news channels did a little story on him and published a little article on him afterwards. That's him playing basketball in his driveway 3 months after surgery. But I think including things like this really, again, builds that culture and that cohesiveness that is so important to team building. So the summary principle 3, success really comes from tiny incremental pushes in the right direction. It doesn't happen overnight. Once you have the right people on the bus, it's important to have a way to show them periodically that what you're doing is worthwhile and that it is working. And so for us, the way that we do that is that monthly QI conference. It's educational, it allows for tracking of progress, and it builds culture. Principle 4 is that new technology should be seen as an accelerator towards a goal, but not as a goal in and of itself. Especially in spine and joints, there are so many technological developments happening in orthopedics, it's sometimes hard to keep track. In spine, we have navigation, we have robotics, we have 3D printed guides, we have artificial intelligence that allows us to create custom rods that restore sagittal alignment more optimally. So our process has really evolved towards a close evaluation of the effect of these technologies on our surgical performance and outcomes. So an example of this is looking at 3D printed guides. I think you've probably seen Andy or Steve or Tom in some instances use these 3D printed guides that are pictured in the upper right here, where the guides really allow for mechanical guidance of a drill and a tap to be used to cannulate the pedicle. So we looked at this as I started using this for some cases at Yale. And what we found was that the use of these guides did seem to be associated with a lower estimated blood loss, but the surgical time was basically the same, and the implant costs were significantly greater. Interestingly, we found that 3D printed guides, as shown in this graph here, and the blue line is basically the time per screw when using a freehand technique, and then the red line is the time per screw when using the 3D printed guides. Our residents tended to act more efficiently with using the 3D printed guides and performed at a similar level to a fellow or an attending placing freehand screws. So that may be one advantage of using them, but as a result of this study, I'm no longer routinely using these guides because of the increased cost, and have evolved towards using them only on a case-by-case basis, more with the aberrant anatomy, the kids with NF and very small pedicles or congenital scoliosis. Other technologies that we have evaluated or are currently evaluating include the use of standard navigation, which we decided to abandon because it tends to be more cumbersome. It increases time, introduces contamination risk. So what I've evolved towards in terms of my process here is just to use a check scan. So we'll place freehand screws and then do a 3D spin to make sure that all the screws are placed appropriately. 7D is a newer technology. You can see that pictured here. It incorporates machine vision that marries a number of data points to a preoperative CT scan and allows that machine vision to do your navigation for you. That's an interesting and intriguing new technology that we may be acquiring soon. And then the use of the pre-contoured rods that I showed earlier, I think that's something we're actively investigating, and I've been using them pretty much for every pediatric spine case recently, and we're about to look a little bit more about what the effect of that is on sagittal pain parameters once we get 2-year follow-up on some of these patients. And then just a word about fusionless surgery. I think many people in this room who do a lot of pediatric spine are very familiar with the work that's being done to advance the field potentially in terms of doing things like a vertebral body tether, which is a fusionless procedure to correct scoliosis. I think the key question here, is it really better? Josh Pays, who's at the Philadelphia Shriners Hospital, a center where numerous patients come from all over the world to get tethers done, really importantly and honestly showed that the motion preservation associated with VBT may not be clinically relevant when compared to patients treated with selective thoracic fusion. I think that was a very honest look at whether or not this is actually pushing the field forward. And especially when you consider that the reoperation rates, according to this JBJS open access article by Jason and Ari, are much, much higher with vertebral body tethering to the tune of 14% with VBT versus 0.6% with a posterior spinal fusion. I think it definitely gives a lot of us pause and makes us really want to critically evaluate if new technology is adding to your core value proposition. I think that's the main take-home point. And for me, I think an important message to convey to the residents is not to get caught up in the marketing game when it comes to new technology. So the summary principle 4 is that new technology should be seen as an accelerator towards a goal, but not as a goal in and of itself. Remember your core value proposition and incorporate technology that adds to this into your practice. Finally, principle 5, success requires facing the nasty facts while never losing faith. I think this is a really important, I have a whole talk actually on managing complications that I give to our residents at Yale. And a lot of these habits I learned from Andy, to be honest, just the way that he manages things when they don't go exactly according to plan. But I think the important thing is to keep faith in your process. I include this picture of Larry Lenke from Columbia holding a 3D printed spine model because it's that same level of preparation. People who have athletic backgrounds will understand that that level of preparation and rehearsing mentally what you're about to do really gives you that confidence to step into the OR and do complicated cases. And I really like this quote, chance favors the prepared mind. So having an honest, steadfast process, not only intraoperatively, but also for managing setbacks and complications, it gets you back on track to ultimately achieve your desired outcome. And I think that handling complications really goes back to level 5 leadership principles. In the book, this section talks a little bit about Admiral James Stockdale, who was a POW in the Vietnam War. He said that you must never confuse faith that you will prevail in the end, which you can never afford to lose, with the discipline to confront the most brutal facts of your current reality, whatever they might be. And when he elaborated on this, he was a POW for 7 years. And what he noted was that the people who tended to not survive and die first were those who were the eternal optimists, so to speak. They thought, I'll be home by Christmas or I'll be home by Easter, but then Christmas and Easter would come around and they were in denial and they weren't home. And ultimately, he was able to have that, to balance that dichotomy of knowing that ultimately, yes, he was going to get home, but he would need to deal with a lot of stuff first. And I think that really is a key when kind of drawing upon this principle. So an example of that, I showed this slide earlier, 172 cases, 6 surgical site infections in that span, but 3 since July 2022. So this actually prompted a meeting with hospital administration to discuss why our team was having a surge in surgical site infections. And I think that the natural response would be to say, hey, 3%, that's pretty good. It's pretty much on par with what we're seeing nationally in terms of surgical site infections. But again, it goes back to level 5 leadership. You need to subjugate your ego to the mission. And it really actually did lead to a productive conversation where we looked at some of our active processes for preoperative, intraoperative, and postoperative ways to prevent postoperative infection. Another example of confronting the most brutal facts of your current reality is dealing with surgical complications. So to introduce this topic, I will talk about a case that I did a few years ago. It's actually one of my first cases back after COVID. It's a 12-year-old female with a right thoracic curve, but probably more important than the coronal plane, we always talk about this in conference, is the sagittal plane. And the sagittal plane shows that this kid also has a pretty significant thoracic kyphosis. And so this is her spinal cord. You can see in this axial view that this is the left side where the spinal cord is basically plastered up against the pedicle body junction. And there's a bunch of CSF dorsally on the right side. But this is basically what Larry Lenke would classify as a type 3 cord, according to the spinal cord shape classification system that he published on a few years ago. And the type 3 cord has about a 28 times increased odds ratio of having neuromonitoring loss during surgery. So with this case, I'd educated the family a little bit about some of the preoperative risk. We placed screws except around the apex. We placed everything from T4 to L1. but I left T8, T9, and T10 empty to do posterior column osteotomies. I did the first 2 osteotomies, no issues. Motors and SCPs are at baseline. So during the posterior column osteotomy on the left side, I'm the one holding the Kerrison ronger. The motors and SCPs drop out on the left side only. There was no apparent concussive maneuver to the cord. However, the space ventral to the left superior articular process of T8 was really tight as the axial MRI showed. Right side was normal. We followed our checklist, our process for neuromonitoring alerts, but even after bringing the pressure up to 90 to 100 for an hour, the motors didn't return on the left side. SCPs were only 50%. And so we decided to stage the procedure. I removed the apical screws, obtained an urgent MRI CT. I did place an intraoperative one called the Dan Ciccato, one of my mentors. I think that's always an important thing when you're faced with this situation. But then when I was walking out to talk to the family about what had happened, this person, Andy's kind of example also popped into my mind. But Tony Herring's words, he's the Chief of Staff Emeritus at Scottish Rite Hospital for Children, definitely kind of stayed with me. He's published a lot on how to avoid the collateral damage, the second victim phenomenon of complications. And in a paper that he wrote, he stated, the author has experienced and taught that when a surgeon properly manages a complication, the patient and family often become longtime friends. And I experienced this with this family, and I'm sure many people in the audience among the faculty can definitely attest to this as well for the residents. The surgeon should give him or herself to the patient. The surgeon should tell the patient the truth, the whole truth, and nothing but the truth. The discussion should be calm, unhurried, and in no way evasive. It should include exactly what happened, how it happened, and what the consequences are, and what the prognoses are. And this just, again, goes back to the level 5 leadership principles. Subjugate your ego to your mission. The Stockdale paradox. You can't just believe that you'll only have good outcomes. And I think that that's really the key. When you get into trouble with managing complications, oftentimes is ego getting in the way of doing the right thing. So for me, I just thought about for the 2 weeks between when this complication occurred and when we actually completed our surgery, it brought to mind that being great at surgery in a complex field requires really proper handling of complications. I spent a lot of time each day with the family while they were in the hospital, sometimes twice daily. Sometimes it would be just sitting in the healing garden in the hospital with the father and just sitting there, literally, while he would process and say something, and I would listen. And that was actually therapeutic for me and for him. I explained to him that I'd been here before. I detailed how we could provide the patient, his daughter, with the outcome that we still desired. I never lost that faith. I spent a lot of time leaning on my faith. The picture at the top, obviously, is the church that we go to. Spent a lot of time in there by myself. Leaned on mentors, called Andy, called Dan Ciccato, Tony Herring. I actually even called Larry Lenke, who's not a friend of mine, but had spoken a lot about the type 3 cord. So reached out to him. And it goes back to a Fred Rogers principle of anything that is mentionable is manageable. So just going out and talking to people about what I was going through helped me mentally. And then finally having a great home team. My wife, Angie, was actually, even though I didn't really share much about what was going on in detail, one of the things she said is, I know you're going through something, but you need to be able to put this behind you because this kid and family need you now more than ever. And so even in my home team and my home life, it's really vital to have the right people on the bus. So we took the child back to the OR 2 weeks later. Still, her motors were not at baseline. Her iliopsoas and adductor were present on the left, but nothing below. So what I did here was take some of Lenke's advice. I placed the convex rod first. So for those of you who are still learning about rod correction techniques in spine surgery, the usual maneuver is to place the concave rod first. And oftentimes we'll just do a rod rotation maneuver to correct the scoliosis. But here, the tip and the thing that I do now all the time with these type 3 cords is to place the convex rod first, compress on that side, which allows the cord to drift away from that pedicle body junction on the left. And we got some return of motors to the left foot, but not baseline. So then I did a laminectomy T8 to T10 and did a concave pedicle resection T8, T9, and then motors came back to baseline. And here she is. Afterwards, at 4 months, she was back to full strength and back to playing volleyball at 6 months. I think from a technical standpoint, it highlighted the importance of preoperative MRI imaging in my AIS cases. And I'll scrutinize those going forward for deformity, and then use this temporary convex rod maneuver prior to doing osteotomies on future cases of the type 3 cord. But I think bigger picture was that steadfast process for dealing with the unexpected really helped us, the entire team, myself and this family and this child, achieve the desired results and outcome. So summary of principle 5, success requires facing nasty facts while never losing faith. Again, the Stockdale paradox, always have faith in your process and in your mission. And it's important to really confront your reality head on, as complications are a true test of your ability as a communicator and as a surgeon. And it all goes back to level 5 leadership. Subjugate your ego to your mission. So the last few slides are just on sustaining the success. It can be just as hard as initiating. Your new team members, because there will be turnover, they need to be carefully oriented. And oftentimes memory is limited for OR management and administration. So they need reminders and updates that spine is a lot like cardiac. You need enduring materials, surgical protocols, spine anesthesia protocols, and infection prevention protocols, which are key. And then finally, probably most importantly, it's all about culture. And I think, the things that we do include regular happy hours, gatherings at my house, and intramural football games that we put together. So it's not only about getting them on the bus, but keeping them happy too. So in summary, level 5 leadership, keep it simple. What do you want to be great at? The right people in the right place are the foundation of greatness. Success comes from tiny incremental pushes in the right direction. New technology should be seen as an accelerator toward a goal and not as a goal itself. And finally, and probably most importantly, true success requires facing the nasty facts while never losing faith. Thanks. Happy to take questions.
Talk into this. Well, it's nice to hear your humility, but I would certainly echo that maybe one of the hardest things that we have to deal with as a surgeon and as a person is to deal with complications. And the reason why it's so hard is that when you have a complication like this, and Lord knows I've had my share, and I tell the residents that I've learned from all of my kind of complications, and and you don't learn from your good results, you learn from your complications. But when you have a complication, you have to really be there for the family. And it's so hard to go into that room when you know there's a problem, when you know the family is not happy, when you know the patient is not happy, and it's so difficult, but that's when you have to do it. And I think the way that you explained that, is exactly what you have to do.
Thanks, Andy. It's funny, I give a lot of lectures, obviously, for the residents at Yale. That's probably the talk that I give on complications is the one that they enjoy the most. It does require a little bit of vulnerability to talk about that, but I do think that it is so important to be able to put yourself there, to again recognize what your mission is to help someone. And another important thing I think is that in that interaction that I cited with that particular patient, one of the things that stood with them or that stayed with them was that they knew that I was going to be there no matter what. And even if I wasn't going to be able to solve the problem definitively, I still had faith that I would. But the fact that they knew that I wasn't going to abandon them was so meaningful to them. And I think that's really a key, is that sometimes you will have a complication that you cannot reverse, unfortunately, especially in spine surgery. But the fact that you are not going to run away, I think is something that can be meaningful and impactful to families.
Hey, it's Tim Leddy here. Thanks for coming back. And it's a good talk. It's an important topic, not just the complication part, but the whole idea of excellence and building teams and all that stuff. And, we all like to pride ourselves on excellence. And we all like to be successful at what we do and make a good living and all that other stuff. And it's funny, every once in a while, I'll have a patient that's, discussing, just the surgery and, or sometimes they get into how expensive things are going to be. And I'm like, listen, it's not about how expensive things, it's not about how much I make, when I do the, the procedures, doing these procedures is done in such a way to, make them safe in as best as we possibly can and minimize complications. But where you really make your money is when you have to deal with a complication. It has nothing to do with, your skill. It's like when those things go wrong, you really need to be that person that stands up and does the right thing, all those elements that you talked about. And it is difficult. It is self-deprecating. It's all, all that stuff is so important. And I honestly think we don't talk about it necessarily enough. And I do applaud you for bringing that up and highlighting some of those points. A very, very important topic.
Thanks, Tim. I appreciate the sentiment. And yeah, I think we at Yale definitely saw that there were a lot of topics that we don't talk enough about in medicine. Wellness is among them, how to deal with complications, how to choose a practice. So we developed a little bit of a kind of a hidden curriculum, if you will. And this is one of the big topics that we talk about. And, as I said, the complications talk is one that actually is a larger talk that I usually give. It's usually like 30 to 40 minutes. But I appreciate your.
So I do have one question for you though, along all of those things. What you guys do is very, finite and specific, and it makes it easy to sort of build a team around that because it's that way. In hand and upper extremity surgery, I could do 10 cases in a day and they're all different. And I can operate on a kid and a 90-year-old all in the same day. I think it becomes very difficult to build a team around that necessarily. We do, some of them, are done in a surgery. A lot of them are done in a surgery center. And so we can work with the same group, but, maintaining that high level of interest in all this tremendous variety. Do you have suggestions about how that kind of thing can be done? Because I struggle with that, frankly.
Yeah, it's a great point. And I think that you're exactly right that the components of your team may be different depending on your subspecialty, but I think a lot of the principles can be the same in terms of engagement. And so for me, when I do have new team members, I'll always take time before the case, and it usually ends up being either before the timeout that we do. I'll talk about exactly in a very granular way what we're about to do and how we're going to do it. And I think that education, I've had medical students in the room come back to me and say, that's something different. I've never seen that before, but it was really valuable. And also, scrub techs and circulating nurses, when they have that level of shared consciousness of what our goal is for that case and how we're going to do it and what our plan A is and B and C and D if things don't go according to plan. That level of preparedness, I think, can help. Even if you're not doing, a 6-hour case, if you're doing, a short case, having that same approach to every single one, I think can be helpful to engaging everyone that's in the room. And then, if you do have a situation where you're in an environment working in a surgery center, we have a pretty consistent, team around you, just doing little things like culture building activities, buying lunch for everyone, or getting together outside of work. If we have an early spine day, we'll finish an AIS like thoracic curve in 4 hours. We'll go out to lunch together, and those types of things I think are ways to develop that culture and build those relationships.
And Dom, I would add to that. You and I did this together a lot when we did cases together. Here is building that culture of debriefing. Your cases go well most of the time, thankfully, right? And having that opportunity to say, okay, well, what could we have done a little bit better? The flywheel effect that you alluded to here. So that the next time, Tim, that you do a carpal tunnel with the resident, something about the setup is a little bit easier because you spent that time, and including everybody who's in the room with you in that debrief and making yourself a little bit vulnerable, saying, you know what, I could have done a little bit better at that point in time, I think is really meaningful. And I think that's an important thing with the residents. This is something we talk about in our, educational conferences. We've talked about it. We've done faculty development here. We do this at the educators course, but a big part of it is going in and saying, our intention here today is to do the best we can. Okay. We would like to get from good to great. And that means being inclusive of people, talking about the preoperative plan, really kind of the more complex cases, really talking through, doing the pre-planning, showing the residents how you're doing your pre-planning, and then having that debrief at the end so you carry lessons forward from what you've done before. I think that intentionality really bears through, and your team appreciates that when you really show that you're putting the patient first in that way, and them too, because you bring them along, the whole team rises. Even if the team is turning over, that person left with a lesson that day that they may think about a little bit more the next time they're in the same situation.
Three more.
I had a question and a comment, Professor Tuason, on attrition and turnover. So I think it's easier. One of the hardest things, I think, is keeping everyone on the bus, especially when it's out of their control. In other words, you may have people get on the bus and they want to stay on the bus, but they're removed from the bus because of the higher ups or administrators. Yeah, and staffing. There's a whole list of things. And you mentioned one of the strategies is, like Jack Flynn says, is to constantly remind them, it's like cardiac, but do you have any other pearls or words of wisdom on trying to keep or retain staff when it's not really their choice, to leave the bus?
Yeah, I mean, I think it's all about trying your best to convey the message that this person or these people are so integral to what we do. And here's, and the nice thing about keeping that running tally of data is that it allows me to show them something concrete. And I also participate in a dashboard, a national dashboard of spine surgeons through the Harm Study Group, where it generates a report card every 6 months of how we're doing against, not only the kind of the national average, but also how our processes are improving every 6 months. And so, that's invaluable to me because I just show that to our hospital admin team and say, hey, look, we're doing a great job, but it's only not because of me, it's because of the team that I have around me. So you take that person away from us, it's going to be to the detriment of that outcome. So
I think it's almost, just as important to keep constant communication with them. It's like you do that and you're good for 6 months and then the administrator turns over.
Yeah.
And then you have to get to know a new administrator, keep them involved, keep them kind of in the buy-in process. And I'd share one final comment is one of the best things I heard was when I was down at Jersey Shore from John Tozzi, when he would have this constant issue when he did his joints and talking to the administrators, is he would use the analogy of him taking away their secretary weekly. Every week, I'm going to give you a new secretary that knows nothing of what you do. And I want to see how you do for that week.
Yeah. Yeah.
Groundhog Day.
Before Dan goes, I'm going to jump in. Number one, thanks a lot for a great talk. I think you hit on a lot of important topics, and Steve brought it up. But I think one of the challenges, especially like you probably went to Yale, built your program, and you have that accelerated growth where everyone says, oh, Dom, you're doing a great job. Thanks for this. 5 years from now, everyone's going to forget about the accelerated growth and you're kind of in a steady state phase. And then to the hospital leadership or the executives, it almost loses its value to an extent. Because now they're so, well, nothing's really changed in the last 2 years, but, things are changing incrementally. You're getting a little bit better, but, you're kind of staying there. And all of a sudden they start to look for other ways to get value. And I find that we had that problem here at Robert Wood. We had that problem at Jersey Shore when Dr. Pollinet and Dr. Sahabian built trauma programs and completely changed the way trauma was managed. And the hospitals love those guys. Like, wow, you're doing such a great job. We're making so much money. It's so much more efficient. But here we are 10 years later and like, oh, things are good, but like, what's next?
Yeah.
And that's a real challenge. And I just wonder, and part of it is like Dr. Adelson said, turnover even at the executive level can hurt you. How does that work at Yale? Is it the same issues? Because you've gone through that accelerated phase, and I presume you're kind of at a somewhat steady state right now.
Yeah, no, it's a great point, Charlie. And you're exactly right that that can definitely happen. I think the key to maintaining your own personal satisfaction is, and it's something I tell my 11-year-old all the time about process over results, process over outcome. And so, that hedgehog concept and, continuing to do what you're passionate about, I think that allows you to kind of counterbalance maybe some of the, because I know the feedback from hospital admin is not always going to be great, but instead of focusing so much on that result or that outcome, I just focus on, the processes of what we're doing and how that brings satisfaction and fulfillment. And I think that's really, what it's all about. Not necessarily getting that pat on the back from admin, but rather finding satisfaction in the fact that, day in and day out, the things that you're doing are working towards that core mission.
Great talk, Dr. Tuason. It's great to see you know, as an attending, how much change you can make and be a part of. But, you know, when thinking about you as a resident and like you as a fellow, were there things that you were doing at those points in your like career that were giving you good experiences and tools in order to use them when you came to attaining that role?
Yeah, I mean, I think, you know, it definitely, I was lucky to have really influential mentors whose advice and words stayed with me. And I think I tried to do my best to be a good note taker, to be very diligent about watching the habits of the people I was learning from. And that even continued. It wasn't even just residency and fellowship. I feel like my first 7 years was like fellowship extended. I learned from Tom. I learned from Andy. I mean, we recounted stories of Tom and his going the extra mile for patients last night even. And, you know, that's what he's known for. And that, you know, even though I mentioned Andy a lot in the talk, I mean, every one of my partners that are sitting here, I took a little bit of piece of each of them with me. And the same could be said of my fellowship too. I learned, you know, my quiet habits when casting club feet from Steve Richards, and my way of talking to neuromuscularly challenged patients from Lori Carroll. And so little bits and pieces of each of those personalities have stayed with me. I think that's a good way to approach kind of the learning process, is always being open to what the people around you are teaching you by example, and sometimes by words, but a lot of times just by example. You know, always having that growth mindset and wanting to learn each day. I think that those are the things that, you know, I still carry with me today.
Dr. Tuason, thank you. One good thing I was kind of thinking about is, you know, as like med students and then residents, as a fellow, you're trying to get to be an attending eventually. And so it's not like, you know, you're not always thinking about, hey, how is my practice going to be in, you know, 5 years from now? You're more just like, I want to pass my board exam. I want to, you know, pass my oral boards, get enough cases and have enough volume. When did you feel that as a attending, or like what time period was it where you started to try to initiate a lot of these things as an attending? I mean, it seems like obviously you had a great niche here when you got here. You had obviously Dr. Bo being a great mentor, and you had a good situation. But, you know, for some of us that might not always be the case. Do you think, you know, that there's a time period where you have the leverage in a way to try to push these things through at whether it's at a hospital system or in a practice, or, you know, how? It's maybe not a simple question to answer, but.
No, I mean, I think it's a great question, Rob. You know, you touched on a lot of important points. I think, you know, when you are a trainee, you kind of get caught up in this mindset that I just can't wait to be an attending. So the first thing I would say is don't necessarily get caught up in that, because when you're an attending, the pressures are still there. They're just different, right? And so I think that's one thing I would say to first address the initial commentary. The other thing is that, you know, if your mission is sound, you can come in as a brand new attending with and talk to hospital admin. When we brought in halo gravity traction here, we had to have a meeting with hospital admin to talk about why we were going to do it here, how we were going to do it safely. Colleen and Joel flew down to Texas with me for a day so we could learn a little bit more about kind of how to safely take care of these patients. And, you know, then we presented it and talked a little bit about how we were going to incorporate it here. And now it's pretty close to brand spanking new. But I don't think that there's ever a magic number per se in terms of when you feel confident enough to be able to do that. But I think that, you know, there is definitely an art to talking to the B-suite, and you gain more confidence with that over time. But I think that if you have a, you know, solid reason for wanting to do something, you know, you can definitely do it. And, you know, for me, for the team here, it was really just a matter of knowing that Colleen was going to do whatever it took to take great care of patients. And now look at this halo gravity traction program here. I mean, you guys are doing a fantastic job with it. And it's because of her and him. And so, I mean, I think that it's really cool to see the fruits of that labor.
Yeah, yes.
Yeah, go ahead.
How did you identify that, you know, Yale would be a good place for you to sort of kind of inject the energy that you you had into their program and sort of build it the way you did? How'd you find that?
Yeah, I mean, I think I knew there was an opportunity there, so that was one. And they really were looking for someone to take leadership of that spine program there. So I think that kind of jived with my previous experience, my skill set, some of the things that I'd learned here. I felt that I would be leaving here in good hands with Andy and Steve and Tom still doing the pediatric spine procedures. And we kind of had that infrastructure in place already with the dedicated spine team, the monthly QI meetings that you guys do here. So it was that whole level 5 leadership thing where I felt good that even though I was leaving, the whole team was still going to be in good shape, and the community here will be well taken care of. And the community up in New Haven needed someone to take on the pediatric spine, because really after Brian Smith left there was nobody doing it other than DeLuna, the neurosurgeon. He really wasn't a spine trained, like pediatric spine trained person per se. So he was pretty eager to have an orthopedic partner that wanted to take on some of these more difficult spine cases. So that's kind of how it evolved, and it seems to have worked out well.
I just want to add one more thing, and Dr. Tuason won't say this from the podium, but he's someone who is incredibly dedicated to his patients, and he, as some of you know, has come back here and done cases on patients that he followed. He asks me all the time for follow-up on his patients. I saw someone yesterday right before we had dinner together, and he was excited to hear how he was doing. And I think that's a really important thing that we have a hard time teaching our residents, is that you have to let yourself, you have to let it in a little bit, to take care of patients the right way. And I think a big part of Dom's commitment to, being a level 5 leader, because I really think he is, and, is leaving the ego at the door and being a human being. And, despite the fact that we feel like there has to be this professional barrier between patients and doctors, and there definitely should be boundaries. I should be the first person to say that. But the fact is that, you have to let in a little bit that these are people's lives that you're taking care of, and that there's nothing more satisfying than seeing someone who you've, done a surgery on, or seeing even through a complication and seeing how they're doing afterwards. You have to, kind of let it in and care about that, in an era where we do a lot of, handing things off and sharing with other people. You have to trust the people around you that they're all going to do a good job. And I feel blessed to have a team around me that I always know, if I can't take care of somebody, that, Alex or Andy or Steve or Deidre or Heather is going to do a phenomenal job taking care of them. And, but I also think that at the same time, you have to, kind of own it from the beginning and care about what you're doing. And that's what Dom's always done as long as I've known him. And I know he always will.
Thanks, Tom. Good way to end. Thank you so much to everyone for the welcome back.
I have one more question.
Sorry.
Yeah.
Jason.
Yeah. Thank you for the talk.
Yeah.
I really like the emphasis on like the humility aspect, and then having to balance that with also having the confidence to say like your patients need you right now. That's it. I feel like it's a really difficult balance to strike sometimes. And I was wondering if you ever find yourself drifting too far one way or the other, or if there's anything you do when that happens, or like trying to regulate that.
That's a great question. So we actually, during the talk that I gave on complications at Yale, one of my residents asked me, how do you mentally bounce back from a complication and do another spine? I had to do another spine the next day when I had this encounter. And, one of the suggestions that I got from another resident was to read this book called The Confident Mind by a guy named Nate Zinzer, which I've since read. So Charlie, if you're into audiobooks, this is another good one. I enjoyed this book so much that I contacted the author, who lives in New York, and he's going to come down to Yale and give us a grand rounds in June. And so he's worked with Eli Manning, a bunch of professional athletes as a West Point psychologist, a performance psychologist, and writes a lot about how to maintain a level of confidence for high-level things like sports, surgery, but still maintaining that sense of humility. And it is a very fine balance to strike. But I think that, if you keep the humility at your core, Then kind of build upon confidence by the way that you prepare is kind of the way that I kind of approach it. I take pride in the fact that I feel like nobody out prepares me for cases that I do. There may be people who prepare at the same level, but I think that's what gives me the confidence. And even preparing for a talk like this, I was rehearsing this talk last night, for 2 or 3 times to make sure it was smooth and there were very few uhs and ahs. I mean, it's that level of preparation that gives me, confidence to do high level things. Right. So we're going to talk about congenital scoliosis next. Again, at 9, is that right?